Hello, readers of the KJR. It is my great pleasure to have a chance to introduce our article with this video clip. The title of the article is Conventional versus Artificial Intelligence Assisted Interpretation of Chest Radiographs in Patients with Acute Respiratory Symptoms in Emergency Department, a Pragmatic Randomized Clinical Trial. I am Eugene Hwang, the first author of the article. Chest radiograph is a key tool for evaluating acute respiratory symptoms in an emergency department where timely interpretation by expert radiologists might be limited. An artificial intelligence-based computer-aided detection tool, or AI CAD, may help the interpretation of chest radiographs by radiologists or ED physicians. However, the efficacy of an AI CAD in a daily practice situation and its impact on clinical decision-making or patient outcome remains unclear. A parallel randomized clinical trial may answer this question by comparison of interpretation with versus without AI CAD in a prospective actual practice situation. So, the purpose of our study was to evaluate the sensitivity and false positive rate of chest radiograph interpretations with versus without AI CAD for diagnosis of acute thoracic disease in patients who visited emergency department with acute respiratory symptoms. And we also aimed to explore the effects of implementing AI CAD on patient management in the emergency department. Our single-center, parallel, and open-label clinical trial was approved by the IRB, and although it was a prospective trial, obtaining informed consent was waived, considering the minimal risk of the intervention and practical difficulty of obtaining informed consent in emergency department. We enrolled adult patients who visited the emergency department with following chief complaints that may suggest acute respiratory disease and underwent chest radiographs for evaluation of those symptoms. For systematic enrollment of participants, we created a dedicated examination protocol for the trial. Severely ill patients based on the initial triage, patients who visited ED due to trauma, and patients already enrolled in the trial in a previous visit were excluded. We randomly allocated participants into two groups, that is, the intervention group, whose chest radiographs were interpreted using an AI CAD, versus the control group, whose chest radiographs were interpreted without the AI CAD. The random allocation and request for the AI CAD analysis were automatically processed by the institutional PACS without any intervention of investigators or other staff members of the institution. A commercialized AI CAD tool that can detect pulmonary nodules, infiltration, and pneumothorax in a single frontal chest radiograph was used in the trial. The AI CAD analysis was provided for the intervention group participants only. Chest radiographs were interpreted by duty radiology residents, like the usual care in the ED, and we used a standardized reporting form including the binary classification for the presence of any abnormality suggesting acute respiratory disease. The management of participants followed the existing policy of emergency department and the decision of ED physicians. Meanwhile, the AI CAD results of intervention group participants were also provided to the ED physicians. The primary outcome of the trial was the sensitivity of radiograph interpretation for any acute respiratory disease. The reference standard for the diagnosis of acute respiratory disease were defined by medical record review at least 30 days after the ED visit. Secondary outcomes of the trial included the false positive rate of interpretation, turnaround time of interpretation, frequency of chest CT acquisition, turnaround times to decide CT acquisition or antibiotic administration or refer to other departments, and the length of stay in the ED, and finally the rate of revisiting ED within 30 days. A priori sample size estimation based on the result of our previous retrospective study led to a target sample size of 4,862 participants in total. The associations between the use of AI-CAD and various study outcomes were investigated with mixed effect models to adjust these potential confounding variables. We enrolled participants between June 2020 and December 2021. 3,576 participants were enrolled, which did not reach the target sample size. About 1/3 of radiographs were obtained using portable scanners, and the most common chief complaint of visiting ED was fever, followed by dyspnea, chest pain, and hemoptysis. Diagnosis of acute respiratory disease was confirmed in about 27% of participants, and the most common diagnosis was pneumonia. We found no difference in demographic and clinical characteristics between two groups, suggesting an appropriate randomization process. This is the main result of our trial. The sensitivity of chest radiograph interpretation by duty radiologists, which was our primary outcome, was 67% in the intervention group and 66% in the control group. The sensitivity did not show an association with the use of AI-CAD. The false positive rate of the interpretation and other secondary study outcomes also did not show associations with the use of AI-CAD. These graphs show sensitivities and false positive rates of individual trainee radiologists. The effect of using AI-CAD is quite variable across different radiologists. The most important finding of our study might be that the improvement of diagnostic accuracy of interpretation by using an AI-CAD was not observed in a real-world practice situation, in contrast to the previous results of retrospective experimental studies. It might be due to the difference in the interpretation environment, including the liability of interpretation and a busy practice setting. A limited AI-CAD performance itself might be another important cause of unlimited efficacy of AI-CAD. To enhance the value of AI-CAD in our daily practice, a more specific and real-world optimized strategy for the implementation, as well as an improvement in the performance of AI-CAD, might be required. These are our conclusions. Using an AI-CAD for the interpretation of chest radiographs did not improve the sensitivity or false positive rate for diagnosing acute thoracic disease in patients who visited ED with acute respiratory symptoms. Furthermore, the use of AI-CAD by ED physicians did not affect workflow efficiency and clinical decision-making in the emergency department. We hope that many readers of the KJR would be more interested in the effectiveness and value of AI tools in our daily practice. Thank you for listening.